Thank you all and welcome to this afternoon's session with the Precision Health 5-year celebration. I'm Joan Keiser. I'm going to act as a moderator just for this brief session for half an hour or so. Will you all ask the co-directors your thoughts about the future for Precision Health. They may, although, want to take a moment first to reflect on what they heard in the morning. If I could invite maybe Jenna to start.
Sure, thank you, Joan. And thank you, everyone, for coming today and staying through this afternoon session. We are going to put you to work this afternoon in just a bit. In terms of reflecting on what I heard this morning, so many great thoughts for Precision Health 2.0 or the next 5 or 10 years. The one that really stood out to me was engaging patients. Precision Health has done some of this, but we can always do more. So I'm really excited about that piece of it going forward.
I appreciate everybody being here as well. It's been really exciting and great to reconnect with folks as over lunch and stuff too. I think I'll just echo that probably the primary thing was kind of patients and communities. That theme came out. I think Amy really emphasized that in a lot of her answers, and that was pretty meaningful for me. And as Jenna alluded to, I think it's a group we've been thinking about, but I think we can always think more and reflect on ways in which we can do it in a more meaningful manner. The other thing is just kind of the complexity of some of the challenges, right? I think the question that was raised about opt-in versus opt-out, I was just sitting there thinking, like, thank God I'm not up there, because it was wonderful to listen to these 4 smart panelists, and I'm sure many of you have ideas as well about how to think through that. But these are issues we struggle with all the time, and there's no real easy answer. Oftentimes it just depends on our own culture, what we want to do as a research organization, and then even more broadly as an institution. And so these are the things that we think oftentimes about, and where do we draw the line? How do we think about diversity? The question about health equity, which is a very prominent focus of our own internal discussions. But these are such big problems, and sometimes they take more than just our own initiative to really work through, because they're almost at a higher level. But I think that what we've kind of oftentimes thought about is how can our voice contribute to this so we can move our whole university forward. And a great example of that is the data sharing model, which I think many of us here who've been involved, in 5 years, the transition from where we've been to kind of where we are and where we think we're heading. And I know he's not here, but Dr. Runge came and gave the opening remarks, and anyone who's worked with Dr. Runge knows his transformation in the last 5 years has been remarkable. And I think that that's part of the evolution of this. This is a really exciting time to be in this space and to really try to tackle these complicated questions.
So a lot of things have been said already. As everybody else said before, I think I'm really excited. I am really excited that we have so many people here, and that we are able to talk to people for the longest time. Sometimes for the first time, people I only know over Zoom, I finally get to see and as actual people. One of the things that stood out to me this morning was the focus on actual impact on patients, particularly when in the genetic space. You very easily see yourself as a basic researcher, where what you're doing will eventually downstream in this nebulous space of you don't really know what, lead to better patient care. But if you personally are doing is just basic science, right? Or is basic science, maybe not just there. And seeing how many people here work really hard to bridge that and to accelerate the step from basic science to truly helping patients, for me, has always been an impressive strength of Precision Health, and was emphasized again today.
Great, and thank you all 3 of the co-directors. And I would like to open it up to the audience. This morning we asked you to write down questions on pieces of paper. I think we're a smaller group now. Everyone can hear me reasonably well. I think I'm just going to ask for people to raise their hands, and we'll call on folks to offer up questions. If you feel like you want to write it down, feel free. But I'd like to open up questions for them. And let's start right there.
Really, congratulations. When we started 5 years ago, to come up with a concept like data direct to be accessible so that I can ping a member in ethology. Oh, we have that question. Go there, find out. And they usually ask, what do you mean? Yes, they can. And this is really an incredible achievement. Empowers clinician scientists to ask questions or to find out if questions are askable in our environment in a really transformative way. It looks easy and it has been anything far away from that. And really kudos starting from the regulatory people and all the underlying concepts behind that to really advertise. And please, let's continue to make this resource known. And it's not known enough, it's utilized, but it's not utilized enough. It should be a standard approach whenever a clinician scientist has an idea. First thing to go is look in data direct, and usually the idea gets better and gets more approachable and implementable. This is really an aspect where I would ask you, all of us actually, not you, all of us in the room, to do a better job. One thing we have learned in the kidney precision medicine project, it helps a lot if we define user personas, meaning what are the different types of users we know we have present in our community, and then do outreach into community stakeholders who are defined and learn who is out there and what questions they have, how our current tools are responsive to those questions, and how we can change and enhance the tools in that way. User-centric design, we do it all the time, but it's really an aspect finding new user communities, and patient participants are one of the key communities in the precision medicine project we serve first. I would encourage us also to include in that, because it changes the dynamic fundamentally. If we talk to a community where we need to build trust to show them it's their data, and we are doing this in different ways for them, and we are listening to them how they want to be communicated.
Great. And I don't know if any of you want to comment to that.
Yeah, I think that's it's a wonderful kind of overview of so many great ideas in there. I'm kind of curious, Matthias, as you've been a leader in this space. One of the struggles we have had is and I love the user persona idea, because in some ways that seems to break across our natural organizational units like departments and schools. Because I feel like one of the lessons we learned was we're talking probably at too high a level sometimes. Like if you talk to department chairs, even chiefs of divisions and institutes and centers, you're sometimes talking to the wrong audience, right? They're not going to remember this amongst the list of things. But breaking down to kind of who's actually using, are there natural groups and partnerships? And have you learned things with the user personas? Like what kind of user personas have kind of struck you as interesting or remarkable?
We did a lot of outreach work in our community, particularly with the Kidney Precision Medicine Project, for the first 3 years actually before we started developing tools. And we identified some discrete ones. They're obvious, patient participants and first. Yeah. And then after that comes with the power user, by informaticians, meaning 80% of the people in this room. We serve them well because that's us. We know what they need and how we do that. The next step is to come with the molecular cell biologist who has a good understanding of the data, but has the whereabouts to really transform data in a way so they are useful for them. Meaning we have to do that transformation to them and then serve the data with enough granular metadata that they can embed that into their research pipelines. And that's where we have done a lot of back and forth and developed several of our tools, which you will find now also in Hub Market and Cell Atlas, to reach into this community. here precision health has another dimension which I think is really fascinating. You have the clinician scientist who has obviously a deep understanding of the pathophysiology and of the patient communities usually as well, but a limited understanding of genetic and pathobiology. And empowering them to reach into our genetic data and, with the image analysis we just discussed during the break, which are available from radiology and are actually generated to linked in pathology now. There are two other dimensions where you can reach out and help them to then link their phenotypic aspects to unique genetic aspects, to unique image, and hopefully even histological structure. And learning from them what works for them or not in incredibly busy times. If they click 3 times and after the third click they are not where they want to be, we will not be able to retain them in our program. But there are enough of them willing, I think, to invest in user interviews, user builds, mock-up development, so that we can learn how we can hone in these tools and move forward. I2B2, I think, is doing some of that work, but in a very different context. So I think we have good expertise here. Brian and his team obviously have with Transmart spend a lot of time and experience which we leverage as well, which could also help us to build a tool which is responsive to their community.
So one of the things we're doing there, at least on the genetic side, is the NCORE. But the problem we're running into then is how to make people actually aware of it exists, right? I'm pretty sure I'm telling at least some of you something new, that NCORE is a platform where if you have defined phenotypes, all you need to do is upload the phenotypes and you will have a genome-wide association study within a day or two without requiring any additional know-how, bioinformatics, or anything. Interpreting the GWAS then, of course, requires know-how, but that's its own issue, right? But getting people to use that, even if you build it, we're not in the field of dreams. They don't just come if you build it. So figuring out how to publicize this is its own challenge, and I'd be curious what your experience there is.
It goes back, if you identify who should use your tool, and you can then, you could go to divisional conferences or other elements, you can see who goes in this K award application. Office of Research has that information available. And if you see we have an award, a structure moving forward where these type of keywords are present, there comes an automatic feedback loop, a flag. Are you aware of? And we give you a 45-minute consultation as you are developing your K or your R plan. These are things how we could help you to build your project out further. And then, and this will be a small number, this might be 10, 20 people in a year, but they might tell you where the disconnect is and help you to bridge the disconnect.
Question?
Actually, a statement.
Oh, please.
Did you want to finish?
I think we're good.
My name is Andrew Rosenberg. For those who have not met, I'm the CIO for Michigan Medicine. And when I'm not focused on running and growing a lot of our technology, it's this work right here that I turn to when I think about our transformation more than any other. And with that in mind, and hopefully that statement of support for the criticality of this for the entire Michigan Medicine mission, not just healthcare at the individual or population in a precise manner, but our basic discovery and a variety of our learners, I really can think of nothing that I think will be more impactful than what comes out of this type of work here. No offense to other people working in other areas. And with that in mind, the statement leading to a question is, if some of you saw an opinion piece in the New York Times in early December by Fyodor Erdov, who is a geneticist from Berkeley. It was a really interesting opinion about if we can do gene editing, why are we not doing more of it? And the opinion piece laid out a relatively pragmatic listing of the incredibly complex and expensive, but existing technologies to do true gene editing and disease elimination, particularly in some genetic diseases, but probably others. And that, to me, I've shared that opinion with several of our leaders, because a good, relatively layman's piece to show much of what we're talking about here. So the question now to the panel is, given all the work we're doing in existing genetic-related therapeutics, immunotherapy, CAR T-cell therapy, where are we planning and heading for true gene editing, CRISPR and other related clinical care, and the supporting basic and clinical science required to make that? That's what distinguishes University of Michigan from others. Where are we in that area, and where are we going?
Do you want to start?
Yeah. So Andrew, it's so first of all, thank you for your support. I mean, I think our relationship with HITS has been a really valuable one, and I think that partnership has allowed us to really jumpstart much of the work that we've been doing over the last 5 years, and we hope to continue. I share your enthusiasm as a clinician. It's hard to ignore the massive advancements in the last 5 to 10 years, and it's been remarkable to see. I will say that it's interesting. I've had this discussion with Steve Kunkel. I don't know if Dr. Kunkel's here or not, because I'll give him the mic if that's. But it is a huge undertaking, and I think that I'll just be very upfront and honest about it. I think Michigan medicine should be in this space. I think there are enormous upfront costs, right? I mean, you and I know, it's one thing to do it in a mouse, but to deliver any of these things into a human being is like, it's a massive investment. We do need to move forward with that. I will just say that's not us. I mean, there's a lot of things that we are doing and we're trying to do and move forward, but that particular aspect of gene editing and work like that, although I think we can kind of be adjacent to that and help support it, I do think that we have to think at a larger institutional level about what our role is. There are some of our peer institutions, University of Pennsylvania jumps to mind for a lot of this, but there are a couple of others that are really moving towards this. So I'm excited about that too, but I think it's probably beyond like what our goals are.
Because I really agree with you, and I don't want it to feel at all gotcha or confrontational, and I know you're not in that way, but I was thinking something that Matthijs was saying. How do we either communicate, how do we continue to stimulate, to catalyze? I can't think of another cohesive group who otherwise could at Michigan. We're wonderful, but we're big and we're matrix. And there really is no one person, potentially even one group. But when you look at just that slide right there, Michigan's Precision Health, I do think this is the community to continue to help shape the vision and implement specific elements of it, because there isn't one person. Matthijs, your point about connecting some of the dots, Donna Martin, Vikas Guliani, Chuck Parkos, Eric Fearon, they're all very interested in elements of the AI around imaging. They're interested in the AI around mundane work around imaging. They're interested in actionable discrete data. And then Brian Athey is interested in chat GPT and new AI and working. We know we have the people, but I do think this group can still help stimulate the vision. But the reason I'm bringing it up is even more extreme, extremely expensive, but it's the gene editing piece that I don't hear as much about. That's why I was trying to stimulate that discussion.
There might be one intermediate step where precision health could really get us into a position that when these elements become practical on a healthcare level, that we could facilitate that. And that as we identify causal variants with forward or reverse genetics out of MTR, if we identify paradigmatic individuals where having a cell-based platform is informative. And then as we can reach back, ask them to send us 5 milliliter of ETA blood so that we generate at least cell lines that we have them available as individual patient level systems. And I know that we have discussed that for quite a while. I think we are initiating it as we speak. week, and that will be a nice intermediate step, having the outreach into our population at last. In our rare diseases in the kidney space, we are doing it nationally. We were able to navigate the regulatory landmines for that. And yes, we have multiple commercial partners who are keenly interested to work with us, and even in the minority healthcare delivery system with the APOL1 risk genotype, because it's rapidly progressive kidney disease for African Americans. We have now clinical trials which we are facilitating. ASO, not gene editing yet, but this is at least steps how to facilitate our efforts going forward. And obviously a nice way also to bring our cell biology expertise, which obviously is very strong here, and to connect that to the genotype-phenotype mapping.
Great, I think that was really helpful, Matthias, because what I heard you asking, Andrew, was what are the steps that, and it will be steps. It's a big hill to climb. Other questions for the panel? Jenna would like to speak.
Yeah, I just wanted to echo something that you said, Andrew, with respect to the technology. While it moves fast, a lot of it we already have, right? So yes, we're excited about ChatGPT and large language models, but we've had a lot of AI that has not made its way into healthcare yet. And what we're focused on in Precision Health is really tackling those pragmatic challenges. How do we overcome those? And I hope you all stick around, because we do have, speaking to user-centric design, a member input session precisely for this reason, to help us think about where do we spend our effort in the next 5 to 10 years? What pragmatic challenges are we tackling?
And with that, Jenna, should we turn over to you for?
Yeah, I guess we're out of time. So now we get to turn the tables and ask you all questions. So this is the point in the day where we turn the tables, we ask you all questions, and specifically about the vision for Precision Health 2.0. So where are we going to spend our efforts for the next 5 or 10 years? And I just wanted to, not all of you were here in the morning, just recap in terms of what is Precision Health. So here at Michigan, we explicitly take on a very broad definition of precision health, where we think about science that seeks to combine data from different sources, different modalities, not just genomics, to inform patient care. And speaking to the pragmatic challenges that we're focused on, we're looking at building resources and infrastructure. So how do we collect data? How do we make those data available? How do we then compute on those data? Building multidisciplinary communities, right? Those serendipitous encounters that Amy Cohen spoke about earlier this morning. How do we make those less serendipitous and more often? And then finally, implementation and impact. So how do we translate our discoveries, our findings, our technology to improved patient care? So you're going to break out into groups, small groups, soon, to engage in discussion and think about where we want to be spending our effort. To help with this, I, along with my co-directors and managing director, have thought about a framing for precision health. And precision health, again, it's broad, it spans multiple modalities. It also spans the spectrum of patient care. So from disease prevention to acute clinical care to rehabilitation and chronic disease management. And speaking of matrices, it also will intersect with all these different data types. Right? We have the electronic health record data, genomics data, biomarker data from our biorepository, imaging data. Precision Health now has made available over 500,000 chest x-rays. Physiological data, waveform data, social and environmental factors data, SES data, socioeconomic status data, and data from mobile health and wearables. And we think this framework is useful to think about how your work fits into precision health. So yes, precision health is about genomics and genetic risk prediction, specifically with disease prevention, but it's broader than that. It's also AI for targeting interventions to improve patient outcomes. It's digital trials, like Valentine, that combines data from mobile health apps with geolocation data. And there's a lot of excitement around the use of wearables. And I've heard that mentioned less in the morning, but I think that the use cases are definitely there. And we've seen that with our own use case here in Precision Health through Prompt. So Brahmajee mentioned this study previously, but Prompt aims to reduce the burden of depression by expanding the use of mobile-based treatments. And to date, the study has collected data from over 2,000 participants. And these data are available to all researchers at Michigan. So with that framing and those few examples in mind, I want you to think about answering these questions. So first, how does your research fit in to this framing? And if it doesn't, what did we get wrong? This is iterative, right? We have some time to plan for the next 5-10 years. So what are the gaps in this framing that we need to address? In terms of user-centric design, what are the additional precision health resources, whether they be data, tools, or services that would help facilitate your research? And finally, what makes a multidisciplinary collaboration successful? How can precision health facilitate the creation and success of such collaborations? Because I think that's really, at the end of the day, what makes precision health so strong and successful. So with that, you should have numbers on the back of your name tag. We have randomly assigned you to a breakout room. There will be handouts that have the questions. I'd like you, when you get into your groups, assign a report back person who will speak on the group's behalf, because we will have about 30 minutes at the end to hear from each group. And go.